resolution of the tumor, and she underwent an excision of the tumor with a complete axillary lymph node dissection. So this is her MRI prior to chemotherapy. Here is the mass, and incidentally, she also has a fibroadenoma. And this is after chemotherapy. The tumor mass disappeared and the fibroadenoma stays the same. And this is her resection. This is the clip where the biopsy was performed. This is the fibroadenoma away from the tumor. And we identify this fibrous area, which we call it fibrous tumor bed, and we evaluated the margins as being negative based on imaging findings. So how much residual tumor there is here and what are the margins is questionable, but at this point during intraoperative evaluation we felt that probably at this point this excision is adequate, the margins are adequate, and no further resection was performed. So this is her resection specimen, very ill-defined fibrous area. Here is the deep margin, and it was found that most likely if there is residual tumor, it is microscopic tumor. And on histologic evaluation, this is the sections of that fibrous area, and there were some areas of calcification, but diffuse fibrosis associated with areas of lymphocyte infiltrate, and no viable residual tumor. So now she is stage 0. And in this case, her expected survival for 5 years is over 90%. So this is one of the main advantages of neoadjuvant chemotherapy. The response to neoadjuvant chemotherapy is the single most important prognostic parameter for patients with locally advanced breast cancer. If the patients reach to complete pathologic response, then these patients, no matter how advanced stage they were started and how poorly differentiated the tumor was, they have an excellent survival. And especially now with our new chemotherapy regimens for triple-negative breast carcinoma, if the patients receive this complete pathologic response, they can have an excellent survival. So yesterday we were talking about the molecular classification. So I look at triple-negative breast carcinoma just like the small cell carcinoma of the lung. There is a small percentage of patients who respond very well and their survival is excellent. They can be one of the curable breast cancers, but great majority don't respond and they are the aggressive tumors. And this neoadjuvant chemotherapy evaluation of pathologic response gives us this parameter. So it is very important to evaluate these specimens as carefully as possible, because not the molecular classification, not the other biologic markers, but if the patient receives complete pathologic response, that is the single most important biologic marker that we have today. So it's a very important marker. And unfortunately, clinical examination imaging methodology, including MRI, is not very important. So histopathologic evaluation is the gold standard. In terms of clinical response, a lot of the clinical response based on stromal changes, and up to 80% of the patients can show some clinical response. But again, it's imprecise, and it's imprecise in terms of false positive, false negative. So it is both ways not very sensitive, or it's not specific. So false negative rates for clinical imaging can be up to 60%, false positive can be up to 30%. So histopathologic evaluation is the gold standard to evaluate response to neoadjuvant chemotherapy. Pathologic complete response is defined as complete absence of invasive carcinoma in the breast and no residual metastatic carcinoma in the lymph nodes. This is very important to accept, because if you look at some of the studies, published studies, and some of the study groups, different groups define complete pathologic response differently. Some groups focus on only the response in breast specimens. They do not consider the axillary lymph node. But from biology point of view, axillary response is a lot more important. So this is actually the definition that has been used in MD Anderson since late 70s, and now many multidisciplinary groups also accept this definition. So absence of invasive carcinoma in breast and in lymph nodes. Many groups also have a disagreement in terms of presence of residual DCIS. At the current definition, presence of DCIS does not change the pathologic response, so we are only evaluating the residual invasive carcinoma. So in the complete pathologic response, presence of DCIS is allowed. Depending on the type of the tumor and type of the chemotherapy regimen is used, pathologic complete response occurs up to 5 to 30% of patients. This 30% usually occurs in patients who have HER2 positive tumors who receive anti-HER2 therapy. If the patient does not show complete response, meaning that there is residual tumor in the breast, then it is classified as partial response. Unfortunately, there is controversy in terms of classifying this partial response, and there are different classification systems. The initial classification system was proposed by NSABP, which showed that if there is no recognizable invasive tumor in breast, then it is pathologic complete response. Again, in this definition, lymph nodes were not considered. And the partial response was defined as the presence of scattered individual or small clusters of tumors in the stroma, and no response was defined as tumor exhibiting therapy-related changes, but not significant increase. The second classification system is called Miller-Payne system. In this system, we have 5 different gradings from grade 1 to grade 5. And grade 1 is the one that there is no reduction in overall cellularity, and grade 5 is no residual invasive carcinoma. And the percentage of tumor reduction from 30% to 90% is classified into grades 2, 3, and 4. And this system, again, is a good system, and there are multiple studies showing the clinical utility of this system, but again, does not include the axillary lymph nodes. And the very important fact about this grading system is that grade 5, which is the complete pathologic response, is obviously the best prognostic category, but grade 4 defined as 90% reduction in cellularity, so meaning that there is only a very small amount of residual tumors left. There is a significant drop from good prognostic category. So identification of residual tumor is very important. And the significance of this to us is that especially when we have lesions, resections where the tumor mass is not very easy to identify, we have to put extensive samples These specimens have to be sampled extensively to identify these grade 4 patients. So even focal identification of the residual tumor is significant. Again, the main limitation of the system that it does not include lymph nodes. There is another method which is proposed by our colleagues from McGee Institute, which is called McGee method of estimating tumor volume reduction. On this, we calculate the pre-therapy size of the tumor, and then we calculate the tumor size after chemotherapy, and then using this formula, we come up with the percentage. Again, the system is very good, and it gives an estimation of tumor volume reduction, but it does not include the lymph nodes. In MD Anderson, we use what we call residual cancer burden system, and this system, in the first look, it looks real complicated, but it is very easy to use in clinical practice, and it provides very important information. On this, residual cancer burden 0 is a complete pathologic response, no invasive tumor in the breast, no positive lymph nodes, and then residual cancer burden 3 is minimal response or no response, and then we have two categories of 1 and 2. And in order to calculate residual cancer burden, we evaluate three things. One, cellularity of residual carcinoma over the tumor bed, and we identify the tumor bed, and we identify it in 2 dimensions. We calculate the number, count the number of positive lymph node with metastasis, and then we measure the largest size of the largest lymph node metastasis. As Dr. Halal has mentioned, it is not the largest lymph node, but the largest lymph node metastasis. And if you go to MD Anderson website, which is publicly available website, there is a residual cancer burden calculator. In this, we put in this calculation primary tumor bed. We put in millimeters in 2 dimension, cellularity of the tumor, and we put the percentage of cancer which is in situ versus invasive. And then we put the lymph node size and the number of lymph nodes. And there is a very complicated mathematical formula, which I'm not going to go into how we came up with that. It's complicated bioinformatics. And then it gives us the residual cancer burden class, either 0, 1, 2, and 3. And so obviously if there is no residual tumor, it is residual cancer burden class 0. But then depending on the size of the residual tumor or size of the metastasis, it can be either 2 or 3. And this residual cancer burden has been shown in our initial study, and then we have a couple additional studies that patients who have received multiple different therapies, including patients who have hormone ER-positive tumors and receiving hormonal therapy in addition to chemotherapy, it really separates out patients who have residual cancer burden 0 versus 3. This is the patients 3 who really did not show any response to chemotherapy, and the patients who have 0, no residual tumor, have the best prognosis. All prognostic factors that are important prior to treatment are also important after treatment. So which is the residual tumor size, lymphovascular invasion, lymph node status. And if the tumors shrink down as a single focus, it's a good prognostic category as opposed to these small clusters. And we have to mention about that. So when we report our specimens after neoadjuvant chemotherapy, we say it's like 1 centimeter tumor with a single focus, or multiple foci of residual tumor covering an area of 1 centimeter or by 1 centimeter. So we give again in millimeters, but we estimate the size of the area. How are we doing with time? How many more minutes do you have?
10 minutes would be
10 more minutes, okay. Thank you. So when we are evaluating the neoadjuvant chemotherapy samples, again, identification of tumors that is very important, because as I indicated, even if we have a small foci of residual invasive carcinoma, it is prognostically very important. And it may require a very thorough evaluation of the specimen. Again, it's a very common question, how many sections of the area that we are going to put for histologic evaluation. I don't have a magic number. We evaluate the pre-chemotherapy imaging, and then we try to make a correlation with our resection, and then we decide how many sections we are going to evaluate. After neoadjuvant chemotherapy, sometimes there is no residual tumor, and these cases are easy. Sometimes the tumor shrinks in a single nidus, and sometimes the tumor area is same, but then the tumor fragments into small clusters. And actually, this pattern, as a single parameter when we evaluate it, is also poor prognostic category. If there is a gross tumor, limited sampling is adequate to establish the presence and the size of the cellularity. Just like any other big tumors that we have in breast, 1 to 2 sections per centimeter of the tumor is reasonable. But if it is the tumor bed is fibrous, ill-defined, more extensive sampling is necessary. Again, we would like to keep these specimens oriented as much as possible. Very frequently, we come back to these specimens and take more sections, because sometimes grossly you feel like it is tumor, but when you look at it, it is all fibrosis and there is no residual tumor. So here's a large specimen showing significant necrosis, hemorrhage, so this is most likely therapy effect, but this is a well-defined tumor. So in this case, we will just measure the tumor grossly, and when we are calculating our cancer tumor burden, we will use this gross measurement as the tumor size. And obviously, when we are putting our histology sections, we will concentrate on the more viable areas of the tumor. But we will make a gross description that the tumor, half of the tumor is associated with extensive tumor necrosis. This is one of the problems and the subjectivity of calculating tumor cellularity comes in, because most of us will take sections from the viable areas. Actually, 50% of the tumor is necrotic, and then these areas are going to be a lot more cellular, obviously, than this. So if you are going to include this, how are you going to adjust the tumor cellularity? I don't know. But it's usually, we say it's like 3 or 4 centimeter by 3 or 4 centimeter tumor, and then grossly like 50% is necrosis. And then on histology, we will give tumor cellularity percentage based on the histology sections. And again, if we have a tumor like this, which looks like it is not really affected by chemotherapy that much, so 1 to 2 centimeter section of this tumor would be adequate. But when you have an ill-defined lesions like this, it is more difficult. Placement of clip prior to treatment is extremely helpful, and this is a major point that we always try to get across to surgeons and radiologists, because if we don't have this clip, it's very difficult to identify tumor bed. And then these clips or coils can be identified on gross evaluation. If it's a spring-loaded coil, sometimes when you section this, this jumps out, so you have to be really careful. And nowadays, the smaller clips are used. They don't use these coils anymore. Even for mastectomy specimens, we would like to have the specimen X-ray whenever it is possible. And this is for two purposes. One is to make sure that we have the specimen, so when we put our sections together, we can recreate the tumor size. And secondly, we would evaluate the margin during the surgery. In this case, for example, the fibrous tumor bed appears to extend to the margin. So in this case, we would report that the fibrous tumor bed extending to the margin, and most of the time the surgeon would evaluate the deep margin if he or she is at the fascia, if a skeletal muscle has been removed, or how does the skeletal muscle look like. They may take additional margin. So at that point, it is surgeon's decision to take additional margin or not. And sometimes they cannot make that distinction, and they ask us to do frozen section of this. And I am completely comfortable to make a frozen section of this large fibrous area, because at this point I am looking for large areas of residual invasive carcinoma. I am not looking at one single, carcinoma cell. So if it's a completely fibrous area, then we will say at least at the margin it's negative. So this is the same case, and it looked very ill-defined, and it was close to the ink. And tumor cellularity is, again, the assessment is very subjective. Some evaluation systems, like the McGee evaluation system, looks at the tumor cellularity in the core biopsy and compares it with mastectomy or resection specimen and gives a reduction. However, as we know that the tumor cellularity can be very variable in different areas of the tumor. So yes, when you have a 90% versus 5%, it's easy to evaluate, but is 60% versus 70%, again, I find it very difficult, and it is very subjective. And again, sometimes you can have these large areas of fibrosis and then areas of pockets of residual tumor with hypercellularity. And when we are evaluating that to calculate our residual cancer burden, what we do is, for each slide, for each section, we give a percentage, and then we get an average. So that will be our average tumor cellularity. And sometimes you can have areas of mucin, and sometimes you can have these small clusters. So it really, you can see variable changes. In addition to tumors, the normal breast parenchyma show a lot of changes. The most important of these changes is that you should not call something malignant in normal breast parenchyma, because based on cytologic atypia. Similar changes can occur in the lymph node metastases. Again, when you are trying to call something metastatic carcinoma in the lymph node, you have to be cautious, and then the cellular atypia, you should allow that. If a lymph node shows extensive areas of histiocytic and inflammatory infiltrate, this is not necessarily an indication of area of lymph node metastasis which completely responded. This is non-specific. If you would like to say that there are some areas of histiocytic reaction consistent with therapy effect, it's acceptable, but the most important thing is not to miss metastatic carcinoma. So the number of positive lymph nodes is important. Even the small clusters are count. Just like evaluation of specimens without chemotherapy, extranodal extension should be evaluated, but because of the lymphoid atrophy, it might be a lot more difficult. So the take-home messages for neoadjuvant chemotherapy samples is that pathologic response is the most important predictor of survival. So we have to look for and then see if there is any residual tumor. And in terms of classification of partial response, there is definitely an element of subjectivity, but using a methodology, either MD Anderson system or Miller-Payne system, whichever system that you are going to use, it is important to stick to criteria to be more uniform in your clinical practice. And we have to be very familiar with the chemotherapy-induced changes in non-neoplastic tissue, not to mistake it for residual tumor. And when we report our specimens, just like any other specimens without chemotherapy, we would include the size, histologic type, cellularity, margins, lymphovascular invasion, and lymph nodes. Grade usually is not given after neoadjuvant chemotherapy because we have significant psychologic atypia after chemotherapy. So we usually say invasive ductal carcinoma with therapy effect. But if you think that there is a major discrepancy between core needle biopsy and excision, you can make a comment about that. Thank you very much for your attention.
Thank you, Professor Shaheen, for this excellent presentation. And we will allow only 3 questions for the time delay we have.
Okay, before we go to that, Dr. Halal gave a couple questions, and this combines her presentation and my presentation. It is one of the questions, counting lymph nodes if we have a single large lymph node metastasis. She presented a case that she's had a patient with a 3 centimeter lymph node metastasis, and the axillary lymph node dissection did not have any additional lymph nodes. So how do we report this? If you are sure that it's a single lymph node, which you said you were able to identify the capsule, then this is a single lymph node. This is a single lymph node 3 centimeter metastasis. And it really does not count that all the other lymph nodes. And we would say that this is not a complete axillary lymph node dissection. So I would not say this, maybe the other lymph nodes were atrophied and it's very difficult to identify, but this is a single lymph node and it's a 3 centimeter metastasis.
Very large size, but not compensate.
I'm sorry. I'm sorry for surgeon, but
there is an opinion if more than 3 centimeters, usually they are multiple matted lymph nodes.
Well, but if it is the case, that's the thing.
Even if I couldn't find
she was saying that she was able to identify the capsule around it, then it's a single lymph node.
The capsule will be destroyed in the middle, preserved on the surface. Usually, if 3 centimeters or more, usually these are mated multiple lymph nodes.
Could be, but at that point, we don't know that. And then a lot of the times, more than, I am right, you were right, to me that's not the important. What are we going to do patient is more important. And with a 3 centimeter lymph node, the patient is going to have axillary radiation with booster axilla. So to say that it is 3 positive lymph nodes, 1 positive lymph node, it may not be that important at that point. And if this is a neoadjuvant chemotherapy patient and having this tumor, she's going to go to the residual cancer burden 3 category, so she's going to have a full prognosis. So what is going to happen to the patient is a lot more important.
So that's it. You have a question?
Yes.
Well, thank you again. I think your talk was all about neoadjuvant chemotherapy. Would the same thing and rules apply to the neoadjuvant hormone therapy?
Correct. I mean, neoadjuvant hormonal therapy, our complete response rates are usually a lot lower. There are very few protocols actually for neoadjuvant hormonal therapy alone, and it is predominantly for low-grade lesions with extensive ER positivity. But the response rates are usually a lot lower than chemotherapy. Yes.
Okay, in Villarpen system on grading, there is grading depends upon reduction in cellularity.
Compared to what?
Compared to core biopsy.
To the core biopsy.
Correct.
Okay, thank you. Are you advising to use the specimen radiology as anti, because we don't use it in our practice?
I find it so helpful, and of course it really requires major equipment and major rearrangement of the laboratories, but if it is possible, I find it so useful. And I have multiple visitors, all the time, and then people come and say wow, it is so helpful. I mean, people really, it is very helpful. And again, it would, in our case, we have our pathology unit is next to surgery, so a surgeon comes and goes all the time to look at the specimen, and then we call radiology, and so it's a very good communication. It really requires a good communication among the 2 disciplines. Yes, sir. Last question, yes.
Regarding cases with complete pathological response, the surgery is just the local control of the disease. So what is if the patient has a complete pathological response, why should we do surgery?
That's an excellent question, and a lot of people are asking that. Unfortunately, until we evaluate the specimen, we don't know that. If there is a clinical technique, like for example, if we come up with an MRI that is so specific and sensitive, then there is no need. But until we resect it, we don't know it's a pathologic complete response.
Is it possible that multiple core biopsies from the tumor bed or the lymph node will help in that?
That's true. People have tried multiple things, but as I showed you, sometimes it's very difficult to know where the residual tumor is. So it is not that easy. Like when you look at this specimen like this, where are you going to do your core biopsies clinically? I mean, it's a large areas of what we call a fibrous tumor bed. And even, as I said, at least 30% of these cases, I go back to specimen and put additional sections. So yes, development of an imaging study, and people are looking into molecular imaging and the more specific MRI evaluations. If we have a method to determine which patients receive a complete pathologic response, that would be wonderful.
Excuse me. If we have
No, I understand. I'm looking at, she is the moderator. So.
Okay, there's a short question. We will allow it because we are short
okay,
of time.
actually I have 2 questions.
No, just one.
Okay. If we have a very abundant, dense plastic stroma, announced few clusters of malignant cells, and no necrosis at all, do we consider it as a response to chemotherapy?
Yes, we say there's a small foci. We estimate the area of residual tumor. Like for example, we would over here, let's say that you have a small focus here, you have a small focus here, and you have a small focus here. We measure this area, estimate the area, and then we say the residual tumor is 5 by 6 millimeter, and the tumor cellularity is 50%.
Thank you, Professor Sahin. And now I will